The House Health Policy Committee will come to order. If everyone can take their seats, please. Would the clerk please take attendance?
Chair Rogers.
Here.
Representatives Whitsett. Carter.
Here.
Hadsma.
Here.
Neely.
Here.
Glanville.
Present.
Kafia.
Here.
Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Reinkens.
Here.
Vanderwall.
Present.
Filler. Mueller.
Here.
Van Workum. Roth.
Here.
Schmaltz.
Here.
Thompson.
Here.
Madam Chair, you have 16 members present. You do have a quorum.
Thank you. Representative Farhat moves to approve the minutes from our meeting on September 20th. Seeing no objection, minutes are approved. Today we will be referring House Bills 4885 and 4923 to the Regulatory Reform Committee. We will then be hearing testimony on Senate Bill 384, a Senator Hertel bill prohibiting discrimination on insurance coverage for living organ donors. To accommodate schedules, we will hear a presentation regarding infant and maternal health, the disparity in outcomes and their causes, as well as the challenges in meeting the particular needs of pregnant and postpartum individuals. Returning to legislation, we will then hear testimony on House Bill 4101 from Minority Vice Chair Vanderwall, which deals with limited licensing for speech pathologists. First, we will take up the bills to be referred. Representative Carter moves to refer HB 4885 to the House Committee on Regulatory Reform. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reinkens.
Pass.
Vanderwall.
Yes.
Filler. Mueller.
Yes.
Van Workum. Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 15 yeas, 0 nays, 1 pass. House Bill 4885 is re-referred to the Committee on Regulatory Reform.
Representative Carter moves to refer House Bill 4923 to the House Committee on Regulatory Reform. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reinkens.
Pass.
Vanderwall.
Yes.
Filler. Mueller.
Yes.
Van Workum. Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 15 yeas, 0 nays, and 1 pass. House Bill 4923 is re-referred to the Committee on Regulatory Reform.
Could we please reconsider those two since we just had a member join us? We will go back to Representative Carter moving to refer House Bill 4885. Madam, go ahead, please call the chair.
So we need a motion to read.
Yes. Okay, we will House policy policy will resume, and we are going to move on to Senate Bill 384 from Senator Hertel. We will also hear from the bill sponsor's Chief of Staff, Dr. Mona Doshi, Medical Director of the Living Kidney Donor Program at Michigan Medicine, Eric Ditchman with the National Kidney Foundation, and testifying jointly David Galbensky, a living organ donor recipient, and Mark Dybus, living organ donor and brother-in-law to Mr. Galbensky. To provide an overview of the bill, we have Senator Hertel's Chief of Staff, Kelly Steck. Welcome to the House Health Policy Committee. And she is not here right now. We will go ahead and call the chair. Happy Thursday, everyone. We are going to roll with this, and I appreciate Minority Vice Chair Vanderwall's flexibility. So we will go to House Bill 401. Joining us to testify, we have the bill sponsor and Minority Vice Chair Vanderwall, as well as testifying on behalf of the Michigan Speech Language Hearing Association, Kelly Pierce, who is a licensed speech language pathologist. Begin whenever you are ready.
Thank you, Madam Chair, and thank you, committee, for allowing me to testify on 4101. 4101 addresses the issue that has arisen with those looking to finish their licensure as speech language pathologists. Before an individual can be fully licensed and practice independently, a speech language pathologist in the state of Michigan, they have to complete over 1,000 hours of supervised clinical work. As part of this process, they hold a temporary license while they complete their clinical hours. Currently, they are issued a 12-month temporary licensure. During this time, they must complete all the required hours. The law currently has no provision for extending this license. With everything we have been through in the past couple of years, such as remote learning, unplanned medical situations, reductions in workplace employment, it has become difficult in many cases for those postgraduates to be able to get their hours they need in the 12-month time span. This bill extends temporary license from 12 months to 24 months and allows for a 1-year renewal option if the individual meets the other license requirements. We worked with our partners at LARA, and I believe this is common sense language that will help people realize their career goals while meeting a need here in the state of Michigan. Thank you very much for the opportunity to testify today. I'm looking forward to working with you on this bill, and we're excited to have the opportunity to fill a void and make sure we have more people enter into this field. Thank you, Madam Chair. I'm available for questions, or if you want to wait until we're fully done with testimony, we can answer at the end.
Yeah, let's go ahead and go forward with Ms. Pierce.
Hi, everyone. Chair Rogers, vice chairs, and committee members, thank you so much for hearing House Bill 4101 today. As Representative Vanderwall said, this bill modifies the educational limited license that our clinical fellows need to complete their, finish their training and get their full license as a speech language pathologist. This 12-month non-renewable license is just untenable for some people. I wanted to share a story of an SLP who was significantly impacted by this. Her name is Kelly Miller. She was hoping to be here today but couldn't make it. She recently graduated and applied for her educational limited license and started practicing part-time. At the time that she received her limited license, she also had a private voice clinic that she owned and was working as an adjunct professor at Western. So she was doing her licensing, her supervised time, part-time. She received, after the 12 months was up, she had approximately 240 hours left and received notification to renew. When she tried to renew, they said that she could not. Her only choice then, after completing over 1,000 of these hours, was to start over and start a new 12-month period to collect 1,200 hours or move out of state. She had to borrow her sister's camper, move to Ohio, and live there for 9 months, leaving her husband and 2 children at home for the summer. This cost her over $5,000 out of her own pocket just so she could complete these hours. She's finished her 1,260 supervised hours and is back in the state with her family. She still can't practice because all of her paperwork has not been processed. She estimates it will be about until November until she can actually start working as a speech language pathologist in the state. She's done all the education, the schooling, the supervision. She cannot practice. This 12-month non-renewable license doesn't impact a lot of people, but the ones it does impact, it impacts significantly. We did a survey of graduate students in 2021 to ask their thoughts on this bill. About 65% of them plan to stay in the state of Michigan once they graduated. 25% said they were considering it. Almost all of them are concerned that they will not be able to meet this 12-month requirement for completing their clinical fellowship. As we're all aware, the state of Michigan has a workforce shortage. This also impacts speech-language pathologists, and we need to keep qualified individuals in the state and practicing. This bill was proposed in 2022 as Senate Bill 811. It passed through the Senate unanimously and was ready for a vote at the end of last year. However, because of the limited number of meetings in the 101st legislature, it was not, and it died on the floor. So we are asking that you recommend House Bill 4101 for a vote, and keep our qualified SLPs in the state. And thank you for your time.
Thank you for your testimony. And it looks like we have a couple questions. Representative Reingans.
Thank you, Madam Chair. Thank you for being here. Thanks for reintroducing this. I agree that it makes sense to extend a temporary license period for a little bit, but I'm curious why the 3 renewal of temporary licenses are in there. It says, and that's one of the other major changes of this, is to allow this to be renewed up to 3 times. So that would not be just another 12 months. It would be another 36 months potentially on top of that. So I just am curious what
And great question. Actually, what it is we're now moving the one instead of 12 months to 24 months. If there's something that came up and we were short, they couldn't get their hours in, this would allow that to be extended another 12-month period for them to get the time. But what we're doing is instead of a 12-month, it'll be moved to 24. And then if we ran into some unforeseen issue, they could extend it one more 12-month period.
It says 3 more 12-month periods in the bill. It says a temporary license issued under this subsection may be renewed for 3 additional 12-month terms if the applicant continues to meet the requirements of this subsection. And I think that's
We'll clarify that.
a lot longer, and I am happy to talk about amendments,
Yep.
but I don't think it should be that long. As a person who has had a temporary license, the longer you get from finishing your education, the less likely you are to actually get the full license. So, thank you.
Absolutely. I believe, if I remember correctly, that came from a suggestion from Lara to align with other temporary licenses.
Okay, thanks.
Yep.
Representative Miller.
So I appreciate you being here today. I understand the importance of speech-language pathologists. My daughter and I worked hard to get her speech up to par when she had tubes in her ears and it delayed her speech. I understand how great a need it is and what a difference it can make in a child's life. So with this bill, if it passes, how many do you estimate will be able to stay here in Michigan?
I think it would encourage graduate students to stay. I don't have a number. There's when we did this survey, we surveyed all of the graduate students in the state at the time, and it was around 250 total. I think it would encourage them to stay. If they're planning to stay, they're not going to consider moving out of state because of the 12-month non-renewable license.
And how many do we have total? Do you have an idea?
Of
How many
graduate students?
pathologists that we have working right now?
Oh, and there's approximately 5,000 SLPs in the state.
All right, thank you.
Representative Glanville.
Thank you, Madam Chair, and thank you both for bringing this legislation forward. As somebody who personally, as a youngster, benefited from our speech path, I appreciate the work that you do. I have a question about the cost. So I see that the fee is going up from 102 to 183 roughly. And so I'm wondering if there's a reason for that, and then also wondering if there's a renewal fee down the line. Like, how often do you need to get your license renewed, and is there an additional fee for that?
I know that the temporary license was a recommendation from Lara because of the costs that we're going in. I'll have to get you an answer. That's a great question. I believe once you're licensed, it follows the path of licensure. So I don't know that exact number.
Okay, thank you. Yeah, I feel, again, having some personal experience in being licensed in a field, it can be a a little burdensome to have to pay these fees. I mean, it might not seem like much, but it is. Yeah. So thank you.
Thank you. Any other questions? All right. Thanks for your presentation, and we
you.
look forward to
Thank you.
moving those very soon. We do have a couple of cards to read. House Bill 4104 from Michigan Health and Hospital Associations supports the bill, not wishing to speak, and Laura is neutral. We will now hear a presentation on maternal and infant health. Michigan is not unique in facing challenges to positive health outcomes for pre- and postnatal individuals. In fact, maternal mortality rates increased from 20.1 deaths per 100,000 live births in 2019 to 32.9 in 2021. This increase in maternal mortality is concerning, particularly when it does not demonstrate the wide disparity in health outcomes for marginalized communities. Nationally, non-Hispanic Black women are 2.6 times more likely to die from complications with pregnancy. To shed light on this serious issue, we will be hearing from Michigan Council for Maternal and Child Health, Nurse Family Partnership, Dr. Elaine Laws Barker, OBGYN at Sparrow Hospital, Mothering Justice, and the Michigan Chamber for Reproductive Justice. To provide an overview, we have Amy Zagman, Executive Director of the Michigan Council for Maternal and Child Health. Welcome to the House Health Policy Committee, Amy, and proceed whenever you're ready.
Thank you very much, Chair Rogers and members of the committee. I am very pleased to be with you today, and obviously I'm anxious for you to hear more from myself and from the other groups that are lined up to speak. I'm going to go through some slides relatively quickly because in the interest of time, I know there's others who have time restrictions. I'm around all the time. Many of you have had the opportunity to talk already about this issue. I know it's a passion and interest for the chair and for many of you, if not all of you. So I'm going to go through kind of quick, and if you need me, come find me. I'd love to come see you. So you have some information, a little bit of information in your packet about the council itself. We are a member organization, but we really work best in coalition. We are a coalition. We work with others, members and non-members, around issues of maternal and child health, including reproductive health and all child health issues as well. So I just, again, encourage you to reach out if those issues are of interest to you. So framing this positively, because instead of always talking about disparities and how we're lacking, it's really good to talk about what's the goal. So the goal really is birth equity, so that we're ensuring that every individual and family has the opportunity for best outcomes. So we like to think about it in that frame. And so you can see here sort of the common definition of birth equity. I'm going to skip over because the chair already kind of summarized some of this data that demonstrates the disparity that has persisted over time, both among severe maternal morbidity, pregnancy-related mortality, and infant mortality in our state. But I would encourage you to look at those slides and listen. I think Dr. Elaine Laws Barker is planning to speak, and I know she's going to emphasize again sort of what we know about how long we've had these persistent disparities in our state and really in the country. So I want to talk and maybe jump ahead a little bit, not just about the why, but about the how and what's been happening and what more we can do, because it's really going to take all of us. Often when I'm in your offices, you all are very eager to help and asking what's the one thing I can do to help. This is not a one thing problem, unfortunately. This is every legislator could do one thing, every community group could do one thing, every profession could do one thing, and we all need to do all of those things consistently. So what we have seen is a much greater awareness around the need to focus on maternal health as well as infant health, understanding that to have a healthy baby, we need a healthy pregnancy, we need a healthy mom, we need a healthy birthing individual, and so that's been a very welcome focus. We know that the Healthy Moms, Healthy Babies initiatives over the last few years in the state budget have provided much needed resources, and thank you to all of you who have supported the appropriations in the FY24 budget that starts in October. There are significant investments, several of which I will reference. There are federal bills at the federal level called the Momnibus, which will direct federal resources down to the state that we can use in a variety of these projects, and we're anxious to see those bills also continue and those appropriations to continue to move at the federal level. You're going to hear today from organizations working at the community level, and again, just want to emphasize how much we've been trying to lean in and listen about what will make a difference, and just encourage you all to do the same thing. One effort that we made really to do that was a couple years ago, we embarked on something called the Birth Equity Education Project. We identified several key areas and went out and talked around Michigan to groups who were doing work in the areas that you see here, and you have the policy recommendations that came from those conversations. We went out and talked to those who are delivering doula services, breastfeeding, lactation support, substance use and perinatal interventions, and a variety of other areas. We published briefs, which if you were in the legislature at the time, you probably received in your office. If you didn't and you'd like copies, please let me know. Again, you have the policy recommendations that the council made as a result of those sort of deep dives. The next thing I wanted to mention is that Michigan is an active participant in a national effort called AIM, the Alliance for Innovation in Maternal Health. In Michigan, we call it MyAIM. And it's a national effort from the American College of OBGYNs to get at the underlying causes of severe maternal morbidity and mortality, those being hemorrhage, hypertension, and sepsis. Safety bundles have been created to make sure that the response in birthing hospitals is consistent. And so Michigan has been at this for a while. And just this year in the FY24 state budget, there'll actually be state funding to actually help hospitals implement these safety bundles. This is a huge benefit. In the past, we've been relying on voluntary participation by hospitals, and it's not a small undertaking to make sure that staff is trained, to make sure they have the right equipment to respond consistently to these types of emergencies, and to make sure that they have the necessary equipment and staffing, as I mentioned. What we're looking to tandem with that, and hopefully you'll see a number of bills start to come to this committee that we've been working with legislators on. One of them is to establish levels of maternal care in Michigan. 18 other states in statute recognize levels of maternal care. So you may be familiar with NICU levels. You may be familiar with levels of trauma levels. This would be a little bit different. It would be a voluntary designation that a hospital would take on. Anything from level 1 hospitals that would be equipped to deal with low to moderate risk pregnancies, all the way to a level 4 facility that would be able to handle the highest risk conditions, including the most complex obstetric and fetal complications. We're interested in doing this as an effort to tandem with the AIM efforts to make sure that hospitals are aware of their own capabilities and that the public is fully aware and informed of the appropriate place based on the stratification of risk of the pregnancy, what's the most appropriate place for that individual to give birth. So we're hopeful that you'll see a bill come to you soon around levels of maternal care. Michigan has a perinatal quality collaborative. We have a statewide collaborative where everyone working in the perinatal space regularly meets to talk about what's happening. You also have a regional perinatal quality collaborative. And I shared with you a one-pager that talks a little bit about the perinatal quality collaboratives. It shows you the map. I would encourage you, if you've never had a reason to interact with them or if they've not interacted with you, that you reach out to your regional perinatal quality collaborative. What they're doing is looking at local data. They're looking at sort of what are the underlying drivers in that region for maternal and infant outcomes, and they're responding accordingly. Again, big move forward with funding in the FY24 budget that will infuse funding down to the local areas so that they can invest in projects that they know will make a difference based on the specific data in that area. So again, I would just stress that we're hoping that many of these efforts that have been started can be sustained over time because it's not a quick or easy issue to address. So please, if you're interested in contacting your regional perinatal quality collaborative and you're having any type of trouble, reach out to me. There's also a statewide coordinator for the Quality Collaborative. I'm going to just touch real quickly because you're going to hear about some of these things from others who are going to speak. But really what we're trying to do is look at innovations that are being led in communities. So I know that Mothering Justice is going to speak, and they've really been leading the charge in Michigan around licensing freestanding birth centers. We're also been looking at things like centering pregnancy. There's also an investment in this year's budget around supporting centering pregnancy, which is group-based prenatal care, which has proven evidence that can reduce disparities in outcomes. And so we're interested in promoting centering pregnancy. One of the things that we'd like to see happen next is Medicaid reimbursement to make sure that centering pregnancy sites are sustainable over time. And so we've been working with the appropriations subcommittee chairs as well as the department on that effort. Another big advance, or if you think about sort of silver lining from the pandemic, is that we've been learning to do things a little bit differently, right? Many of us are doing hybrid medical visits. It's the same in OBGYN, and there are hybrid models which are now moving into the evidence-based space around being able to do some portion of the prenatal visits telehealth. And one of the things that's important to that is that we make sure that all of the things that would normally happen in an office can happen at home. One of those most important things during pregnancy is just being able to check someone's blood pressure. So we're very interested in making sure that insurance coverage, Medicaid coverage, cover blood pressure monitors for every pregnant individual, not just those who might have sort of previous notice of hypertension or a risk factor. I listed a number of the support professionals that we know are so critical to good birth outcomes: doulas, community health workers, lactation support. We're starting to see some movement in this area. Obviously, there's Medicaid policy now to cover doulas and a policy out right now on community health workers. We'd like to see that extended to lactation support professionals who are also not licensed in the state, but play a really critical role in improving outcomes. There are some really unique tools being used to try to identify underlying mental health and substance use issues, tablet-based screeners, opportunities to keep a dyad together if a baby's born substance exposed. I'm not going to get time to dive into those today, but just know that there are really innovative approaches happening at the community level that I think deserve attention and support. I think we all know, well, many of us who are parents know how stressful it is to bring home a new baby. And so even for those who have a good outcome in a pregnancy, we also want to think about what does it take to support a new family. And so we're very interested in sort of ensuring that there is insurance coverage for perinatal mental health screenings. So perinatal mood disorder can arise both during the pregnancy and in the postpartum period. We want to make sure that there are screenings at intervals both during the actual care for the woman, but also during well-child visits to make sure that we're screening and then connecting to resources. Screenings are never any good unless they're actually connected to resources. I know you're going to hear more from Nurse Family Partnership about home visiting. I can't say enough about how lucky we are in Michigan to have a robust home visiting system. We have 8 different models. We have 6 different agencies in state government who invest in some way in home visiting. We need to make sure that families who are eligible and would benefit from home visiting understand the unique partnerships that can be formed between a home visitor and the family, and how it really can help them thrive. And we really need to help home visitors with the messaging that home visiting is intended to be voluntary. It's helpful. It's intended to be helpful. It is not in any way connected to CPS or intended to criticize someone's parenting, but rather help. And I know you're going to hear more from Nurse Family Partnership about the great work that they do. The other thing that I want to just touch on is all of the contributors to stress that happen during pregnancy as you're thinking about leading up to having a child, and then shortly after in the perinatal period as there's a lot going on with hormones and sort of just healing. In that time when we want families to heal and bond, some of the greatest stressors that we know exist for people are around their ability to leave their employment and have paid leave. I know that's obviously a hot topic right now to talk about paid leave, but there is great evidence to show that it has impact on maternal and infant health. We know that less than 8 weeks of paid leave negatively affects health and increases depression. We know that longer paid leaves over 12 weeks lead to improved mental health, increased breastfeeding, and increased infant immunizations. So I think important for us to keep in mind that there's a reason for that time period, and there's a reason we should want everyone to have access to that. I would also just mention, I already mentioned lactation support. Many individuals want to be successful at breastfeeding. It doesn't always come easy for people, so thinking about what we can do to make lactation support easily available and reimbursed, and also grief supports. It's not always, we started out talking positively, and it's just true that not every journey is always positive. It don't always end in a good way, and so we need to make sure that we have grief supports available, because we know that unresolved grief obviously is usually carried forward for a family, and we know that if we can do better to help them resolve loss during the perinatal period, that we can substantially increase the opportunity for them to be successful with a subsequent pregnancy and parenting. I gave you some resources. Again, most of these are not mine. We didn't create these. The vast majority of these are created actually by the state. I know they're not here to speak for themselves today, but I will tell you that both under the Snyder administration, when we saw increased interest in infant mortality, and now under the Whitmer administration, when we see even more heightened interest around both maternal and infant outcomes, all of these systems that have existed for a long time really working in great concert together, specifically around addressing racial disparity. So everything that you see as far as data from the maternal mortality surveillance system to the fetal infant mortality review, where we're looking at deaths and why they've happened, is all data that's separated by race and ethnicity, so we can actually dig in and look at what some of the underlying causes are, and be very focused intentionally on the differences. So one I'll draw your attention to real quick, and then I'm going to get out of the way, is the Pregnancy Risk Assessment Monitoring System. If you're ever really curious about what do families themselves say about their pregnancy or the period postpartum, PRAMS is a survey that's done with 30,000 individuals every year. They ask them a long series of questions. It's about 90. And they're asked in a very conversational way to get at both what happened during the pregnancy and what stood in the way of them potentially being successful. And it's just a wealth of information. We've done it for years and years in Michigan, so you can look back at longitudinal data, and you can also try to change the questions so they're very relevant. So there are questions now being asked about marijuana use and things that we know that have become more of an issue. And I just, if you're ever wanting to really dig in or you're interested in an issue, it's worth going to look at PRAMS and see if there's a question that's been asked, so you know that it's not just a constituent who contacted you or an issue that I brought you, but rather it's a prevalent issue for individuals.
Thank you. I think we're going to hold questions. I see some for the end, because your question may be answered by one of our presenters. Thank you so much, Amy. Next up, we have Sarah Bryant and Effie Elafogikar. Tell me the pronunciation one more time. I'm sorry. Elafogikar. All right, with the Nurse Family Partnership. Thank you so much for joining us today. Make yourselves comfortable and then begin whenever you're ready.
Well, thank you. Nursing practice for the Nurse Family Partnership Program. I have the opportunity to serve in 6 of our...
Ma'am, can you speak in the mic?
Oh.
I just want to make sure we can hear you. Sorry. Thanks, Chair.
Are we in business? We're in business. Anyway, I just want to thank you. Thank you again for your time and effort and energy in this matter. My name is Sarah Bryant, and I serve as a manager of nursing practice for Nurse Family Partnership Program. I have the opportunity to serve in 6 different states supporting various nurse family partnership programs, and really had the awesome opportunity to also implement nurse family partnership here at Ingham County. So please let me just introduce, just real briefly, nurse family partnership, and then I'd also like to hear our how in a wonderful example here. So Nurse Family Partnership is an evidence-based program with over 45 years of research. We are really steeped in making sure that we make a personal connection and relationship. We do not come with a prescription, we come with guidance, education. What we're there to do is really assess the person that we're with and meet them where they're at. And we do that with 3 objectives in mind, with making sure that there's a healthy pregnancy, making sure that there's a healthy child with great child development, and then we also have a wraparound approach of really ensuring that there's a improvement in economic status as well. So when we think about what do we do to do that, we know that it's going to touch everything that makes us whole and well, and that's what the nurses do. They're personalized nurses. They're paired with a pregnant person and their family. We enroll by 28 weeks, so we're really early on, and we're seeing that family and that child until that child turns 2. So there's great opportunity. I want to offer an opportunity to hear from Effie. She not only has a child that's 10 years old, but was one of the first clients that we were able to enroll right here in Ingham County for Nurse Family Partnership. So thank you.
Well, thank you so much. It's an honor to be here this morning. Good morning. My name is Effie Alafoje Carr, and as Sarah said, I am an embodiment of a nurse family partnership in action here in Ingham County. When my husband and I found out that I was expecting, it was a big, big shock. So I'm sure y'all know that you can have a degree and be broke. Okay, so I had a degree from Michigan State University and was still broke and still managed to, unfortunately, because I was working in public health in domestic and sexual assault violence. We had a grant and was funded for 2 years, and that 2 years was up. And so my student loans, I hadn't even made a dent in them. I wasn't making enough money, and I was now unemployed. I thought I was being a responsible adult. We had been married for about 5 years. We were still using, different forms of protection, and I still found out that I was pregnant. There's that little 0.4% when you're using an IUD, and I guess I fell in that 0.4%. And so I knew that we were going to need support because economically we weren't doing great. Mentally, I was really struggling. So Amy shared earlier that there's not just postpartum depression, there's also perinatal mood disorders. I was very depressed in pregnancy and don't know if it was just hormones, though I have a sneaking suspicion hormones played a huge part. But also like my economic situation, I wasn't sure where the money was going to come from for diapers. Didn't even really consider breastfeeding. I did successfully breastfeed for 2 years, but formula was expensive. I just wasn't sure what was going to happen. And so enter in Liz. Liz was my nurse. She was my nurse from around 20-ish or so weeks of pregnancy until my son turned 2. We are still connected to this day because we built such a lasting relationship that even though she has moved on to other things, we still are very closely connected. She made sure that I had all of the information I needed during pregnancy. She was supportive for me once I gave birth. She is the reason that I actually moved forward and started some support for Black mothers in Michigan who were wanting to breastfeed. And so I've been able to touch about 1,000 women virtually to help support them here in Michigan to breastfeed. And it was because of her encouraging me. I did not use formula. I was able to breastfeed, which was a great cost savings for us and a great health savings for my son because breast milk is a miracle, right? And so I really appreciate all of the confidence that she instilled in me. She let me know that I had my own answers to my own problems. She reminded me that I was a calm and capable person, and she let me know that I could raise this child that I had been gifted with that I didn't expect, right? And so she was a huge success, even in my husband's health outcomes, ensuring that we both got into a good PCP who was then able to support my husband with blood pressure issues that he didn't know he had, right? I mean, it just made a difference across our family, and I'm super grateful. And when you think about the fact that I had somebody who was well-versed in medicine, when my son sprouted a fever and I'm on hold with Lansing Peds and can't get through because there's 6 people in the queue, she's like, hey, you've told me what's going on. Trust your instincts. We went to the ER. He was admitted immediately. It's because of having that support, it made the difference in me being the parent that I am today. And so bear with me. I do have a few notes because I want to share with you about this impact, so that's why I'm looking down. But she also really supported me getting connected into therapy. By 9 months in my pregnancy, it was quite clear that we were having some serious mental health issues because of the perinatal mood disorder of depression. I was able to get connected to a therapist that saw me, came to the hospital when my son was born, because unfortunately I got released and he didn't. So she came and was supportive even on the ground during that childbirth experience. And I was able to work with her for about 2 years of life to just make sure that I was really a grounded mother, that I really got that support through that depression and anxiety of becoming a mom. In addition to that, I would say that where I am now economically is light years different than where I was previously. My son is now 10. He's in the 5th grade. He has straight A's. He got an award for perfect attendance. And every time I pull up to that school, they are tracking me down. He is so kind. The principal is like, he is just so sweet. He takes care of everybody. He's so respectful. And I truly believe it's because of the influence that I had with the community that I was supported to build with Nurse Family Partnership, as well as, of course, we have our own things going on where we get support, but I was taught to look for support and resources through Nurse Family Partnership. In addition, where I am now currently, I am a Mom of This with Mothering Justice, so I have to shout out that organization. I do provide lactation counseling and support now. I am certified. I will be certified as a doula in November. In addition, I do work in public health. I work in substance misuse disorder prevention. My husband works in IT. Our income has tripled since this has started, and it was because Liz really sat down with me. She worked on my resume with me. She helped me believe that I could get back into the workforce even though I was a mom, and we found the right job and the right fit, and it launched my career trajectory back from where it was to being unemployed to getting work that helped us make more money, and it helped me realize that I had a lot of gifts and talents inside of me because she really poured into me. And so my career started again, and we were able to move forward. And so I'm very, very grateful for this program because not only did it remind me that I had desires as a person, it also taught me that I could be a mom and prioritize my health and well-being so that my son could have good outcomes. So I'm very grateful for Nurse Family Partnership. I'm very grateful for Liz. I'm extremely grateful for Sarah, who saw that I needed the support when I was pregnant. When I reached out and she saw my name come across her desk, she ensured that I was paired with a nurse who would be a good fit with me. So I'm very, very grateful for Nurse Family Partnership.
Thank you so much for your awesome testimonies and personal stories. We really appreciate it. Next up, we have Dr. Elaine Laws Barker, OBGYN from Spiro Hospital, joining us remotely on Zoom. If you can turn your camera on, we are ready for you.
Good morning.
Good morning.
Chair Rogers and Vice Chair Wissett and Vanderwall and esteemed members of the committee. I'm Dr. Elaine Laws Barker, a board certified obstetrician and gynecologist and a fellow of the American College of Obstetrics and Gynecology. I have been a practicing physician for 25 years and involved in the maternal infant health space for about 38 years. My involvement began with a grant proposal to the Kellogg Foundation to address the problem of infant mortality in Sacramento, California, in the Black community. And it weighs very heavy on my heart that I have been working in this space for over 38 years, yet the problem continues and in fact appears to be worsening. I do believe that there was a video that they wanted to share this morning, and if they could pull that up, I would greatly appreciate it.
Okay, we're going to have to pause you for a second and then we'll pull the video up. Just give us a second. Thank you. Thank you to our awesome IT support. We appreciate you. I certainly couldn't do it.
My journey. Well, I tell it because it's the one way I have to continually honor my son and his 6 months of life with us. I found that at about 28 weeks, my blood pressure began to accelerate. And the morning of his delivery, I remember being awakened by a team of clinicians, professionals who were coming in. Nobody talked to me about taking me to surgery. You know, you're stressed, you're afraid, and so you just decide to trust the process, even when maybe the process shouldn't be trusted. I'm thankful for every single day of those 6 months that we had his little finger grabbing hours, had his cries, had all of those things that so many women don't have. What is happening in the pregnancy experiences of Black women as opposed to the pregnancy experiences of white women? It's just easier for people to talk about economics, and so they want to say, this is not about race, it's not about Black women, it's about poor women.
But when you start looking at the fact that it's happening across socioeconomic status, across academic status, then you have to ask harder questions that are more difficult to address.
I was struck by the fact that my experience as a highly educated Black woman with numerous degrees was not unusual. Research was demonstrating that Black women with a college degree were still more likely to experience an infant death than white women who had not finished high school.
A lot of the issues that affect the African American person go back to things like systemic racism and toxic stress.
Prejudicial traumas impact the health of Black women and their children in a manner very similar to post-traumatic stress disorder.
That toxic stress causes physiologic issues, increases blood pressure, heart disease, diabetes.
It's chronic stress, it's reliving prejudicial treatment, traumatic events, systemic inequities, and it results in chronic and ongoing poor health outcomes.
Trauma at a cellular level does impact how my body will function and the successful or unsuccessful outcome when it comes to having a child.
How do we unlearn things that people we trust teach us? And if you see in a book that being African American is a risk factor, then how can we not justify that? So many practitioners and so many scholars are just taking things as they see them. But we push against that because race is not the risk factor. Racism is the risk factor. Because race is not a biological construct, it is a social construct.
So a Black woman might know she has an advanced degree, but when she goes in the hospital, she's just another African American woman. And a lot of times when I walk into places, they don't look at me like I'm a doctor. They're more likely to look at me like I'm the janitor.
We have the knowledge. We know what needs to be done. We know that bias and implicit bias and misinformation in the way we train providers is getting in the way. Not seeing women, the humanity of women during pregnancy, as well as before or after, is a pattern. It's a reflection of the unsolved enigma that is America. Did I want to be in this club? This, here's your membership card, your baby's going to die in 6 months club? Did not. And so I'm honoring Mark Howard Kennedy II, who was really our joy and who really made me the mother that I am. I tell you, I don't think I could have loved and appreciated my 3 sons more deeply than I do if I had not lost the most precious gift of my first son.
Thank you for showing the video. If we can bring back Dr. Laws Barker. Thank you for sharing that very powerful video.
Thank you. I was just texting if someone could unmute me. And thank you for sharing and watching that video and living through that experience with Dr. Kennedy, a very prominent member of our community here in Michigan, although very educated, did suffer the tragedy of infant mortality. Is it possible for me to share my screen?
Yes.
So I'm going to share with you a brief presentation to kind of follow up on some of the subject matter that was addressed in the video. And I call this presentation Labor for Life. I'm going to share with you the story of Shalon Irving. Many of you may have heard of her, quite an educated African-American woman, an epidemiologist with the Center for Disease Control and Prevention. She was a lieutenant commander in the U.S. Public Health Services Commission Corps. She dedicated her life to understand how structural trauma and violence affects health over a lifetime, and was quite an advocate for women's health care, specifically African Americans' women's health care. At age 25, she was a recipient of a dual PhD in sociology and gerontology from Purdue University. She had a master's of public health degree from Johns Hopkins Bloomberg School of Public Health, as well as a postdoctoral fellowship completed at the Kellogg Community Health Scholars Program at Morgan State University. But she passed away January 28th, 2017, just 3 weeks after giving birth to her first child. She called attention to one of the widest of all racial disparities in women's health, which is the disproportionately high rates of maternal mortality among Black women in the United States. And this is Shalon. She went to see providers and physicians 5 times after that birth. And on the 5th time, she was handed a bottle of medication for blood pressure and told, just wait it out. But there was no time to wait it out. Within 5 hours, she collapsed and spent the next 4 days of her life as we see her on this screen today. So why focus on birth equity and bringing that back to Michigan? Because every year, about 25 women in Michigan die from the complications of pregnancy and childbirth. And for every 1 woman that dies, 100 more suffer severe, life-threatening injuries, infections, or diseases. And that's about 2,500 women per year. In Michigan, our infant mortality rate hangs around 6.8 to 6.4%, with a national average of 5.8%. And there are racial disparities in Michigan and throughout our nation for maternal and infant mortality. and the morbidity remains a persistent challenge for us. And I'm sure you've heard today that birth equity is the assurance of conditions of optimal births for all people with a willingness to address racial and social inequities in a sustained effort. According to the CDC, about 700 to 800 women die every year due to complications related to pregnancy and childbirth in the United States. An additional 50,000 women suffer from severe complications. And here we look at Michigan and we see the severe maternal morbidity and mortality, and we ask ourselves what contributes to that. And examples include heart attack, heart failure, eclampsia, which is seizures, sepsis, blood infections, and hysterectomies that have to occur sometimes at the time of childbirth. And you can see from this data from 2011 to 2020 that the Black rate is significantly higher than those of others. And this is a data graph that shows through 2015 the significant difference in mortality per 100,000 live births. And again, what's significant about this slide, and it goes from 2015 to 2018, is that Black women were 2.8 times more likely to die from a pregnancy-related cause, which I listed previously. But what is really significant is we know that 63.6% of those deaths were preventable. So if you say that 700 to 800 women per year die in America from pregnancy-related causes, that would be about 2 women per day. But then half of those individuals, one of those people that will die today, a little more than that, actually, that death could have been prevented. And that's where I believe we come in, and that's the area that we can make significant changes. And then again, back to Michigan, Black non-Hispanic infants die 3 more times than white non-Hispanic infants. And infant mortality, and I heard it addressed previously, is defined as the death of a live-born baby before his or her first birthday. And it is expressed in a rate of how many per 1,000 live births. And again, this graph shows that significantly more African American and Hispanic children are dying than non-Hispanic white children. Looking at the US infant mortality rates compared to Michigan, 6.8 to 5.9. Again, looking at the infant mortality rate in Michigan through 2019, still remaining in that 6-point range.
I'm so sorry
And
to
then-
interrupt, but we do have more testimony after yours. If you could kind of condense it over the next couple minutes. We are running short on time. I apologize.
I'm just about done. So you might want to know the causes of infant mortality in Michigan: prematurity, low birth weight, also sleep issues with co-sleeping with parents. And lastly, what I was going to say is we are confronted with the fierce urgency of now. This is a time for vigorous and positive action. And that was said by Dr. King. And I had the fortunate opportunity to be in Washington, D.C. this weekend to visit the memorial and to think about the things that we are dealing with in the infant and maternal health arena. And I just am hopeful that the committee will look at the information that they have received today, have understanding about where we're at, and hopefully where we need to go. And I'm willing to answer questions if anyone has any.
Thank you so much for your moving and important testimony. We appreciate that. And we did receive quite a packet of information, which we will be reviewing. Appreciate your time. Next up, we have Tatiana Amolo with Mothering Justice, and in person joining us, if she'd like to come forward, Cassie Jones McBride with the Michigan Chamber for Reproductive Justice. Welcome. I'm not sure who wants to go first.
Okay. Yes, I can start.
Okay.
Thank you, everyone. Thank you, Madam Chair, and thank you, committee members. Really grateful to be here today speaking with you virtually about these critical issues. So My name is Tatiana, and I am the Government Affairs and Policy Director at Mothering Justice. And so for folks who might not know, Mothering Justice is a grassroots policy advocacy organization that provides mothers of color in America with resources and tools to use to create make equitable changes in policy. So we're really dedicated to improving the quality of life for families in America by empowering mothers of color to take action on American policy on behalf of themselves and their family. So today I'll be focusing on the disparities we see in our communities here in Michigan, and our community partner, Cassie, who's the founder of Michigan Chamber for Reproductive Justice, will be sharing on challenges facing improved outcomes, and she'll also touch on ways to overcome these barriers, including some of the importance of birth centers. We are all together working in a coalition called the Michigan State for Birth Justice. So just for brevity, I will speed this up. I realize we're close to time. So essentially, maternal health is the health of women and birthing people during pregnancy, childbirth, and the postpartum period. In most cases, this encompasses the healthcare dimensions of family planning, preconception, prenatal and postnatal care, in order to ensure what we hope will be a positive and fulfilling experience. As you've heard in all the presentations today, the data that you've seen shows that Black and Indigenous women are dying at alarming rates here in Michigan, as well as across the country. And we see that racial disparities at the forefront of cases in this state, where Black women are 3 times more likely to die during pregnancy and childbirth, especially in urban areas like Detroit and Flint, where the rates are even higher than the national average. And as you've heard, that we see that the data shows the same disparity exists even when we account for income and education levels, meaning that a higher income or education level are not protective factors for Black and Indigenous birthing folks. So even with advanced degrees, Black women still die at higher rate than white women with a high school degree. Black birthing people are also more likely to experience life-threatening conditions like preeclampsia, postpartum hemorrhage, and blood clots, as well as an increased incidence of other pregnancy-related complications like preterm birth and low birth weight. So researchers attribute these disparities to racism within our medical and health system, as well as a lifetime of racial discrimination. Weathering, which was a hypothesis first introduced in the 90s, hypothesizes that repeated instances of prejudice, discrimination, marginalization, and institutional bias push Black women to higher stress levels, leading to accelerated health deterioration. So, simply put, Black women age earlier and faster due to continuous exposure to race-based stressors. So this puts our bodies under more risks for health complications during prematernal and maternal health periods. So at Mothering Justice, we've heard many mamas speak on their experiences of being ignored, mistreated, or provided with inadequate care here in Michigan. So these are some stories that our organizers have heard from mamas when they're out in the communities working with them. So in our Michigan communities, most Black women have high stress levels due to being the caretakers of their communities, whether it be children, relatives, or work-related issues. These high stress situations lead to additional issues such as preterm labor and nutrition deficiencies in mom and baby. Our urban communities are also known to have food and transportation deserts. So we know that a large group of Black women that we've spoken to, as well as non-English speaking women, are met with discrimination when missing appointments or late arrivals due to inadequate transportation. Most offices have a 3-and-done rule, which puts the pregnant person at risk for stress and lack of care. And lastly, we know that many Black women have shared experiences of their medical concerns being overlooked or dismissed by medical staff, as we just have heard. So often this looks like Black women sharing critical health information or symptoms that could lead to life-threatening emergencies with their doctors or nurses. Rather than taking these concerns seriously, medical staff dismiss Black women, stating their worries are overblown, often delaying the time and opportunity to provide necessary life-saving care. These experiences are happening regardless of social strata. Black women's lived experiences and research continuously shows that Black women are met with obstetric racism, loss of autonomy, and high levels of stress during and after their pregnancy, making them more susceptible to health complications and death. So one of the ways in which we'll be talking about what could be potentially helpful are birth centers. So community birth centers, especially those led by Black, Indigenous, people of color, are part of the solution. Birth centers are freestanding home-like facilities where maternal health care is provided by midwives. Studies have shown that birth center care improves outcomes, enhances the birth experience, and lowers costs. So that's because birth centers provide safe, culturally relevant midwifery-led maternal health care for all. And a 2021 study suggests that culturally affirming care provided by Black, Indigenous, and people of color-led birth centers benefits all birthing people, regardless of race. And I'll go ahead and pass it over to you, Kathy.
Good morning. So thank you so much for the opportunity to be before you today to talk about this global crisis and why informed policy around infant and maternal health is so important. I am Cassie Jones McBride. I am the founder of the Michigan Chamber for Reproductive Justice. I'm more importantly the daughter of Mary Alice, who is now my ancestor, but ushers me into these spaces with the truth of her lived experiences. She often talked about her pregnancies and how she was hardly able to carry her pregnancy to term. She almost lost her life each time, and it was a miracle that we all survived. Globally, once every 2 minutes, a mother dies from complications due to childbirth. In the U.S., the statistics are dire for birthing Black people. By the time the sun sets today, 7 Black women would have died in childbirth. That's 138 people a month. That is 18 commercial planes a year dropping from the sky. Imagine 57 buses per year crashing and killing everyone on board. It is a mass tragedy that you never hear about. We must ask ourselves why there isn't an outcry for this known structural violence, and 60% of those deaths are totally preventable. Research has shown that it is more effective if you practice in context, being able to adapt your style, your diagnosis, birthing plan, etc., to respond to the complexities of each patient that you serve. Anti-racist health policymaking must consider how policies impact Black, Indigenous, and other children, families, and communities of color to ensure that the policies do not harm some racial and ethnic groups while benefiting others. For policies to effectively support children and families of color, they must recognize how race and ethnicity intersect with class, ability, sexual orientation, gender identity to shape people's experiences. Just one example of systemic racism in healthcare and birthing practices is the C-section risk calculator. Up until 2 years ago, if you had a C-section for your first delivery, and if you were Black or Hispanic, you were not given a choice for your second delivery, and you had a C-section automatically. But the choice was always given to white birthing people. Because we know that C-section deliveries are very difficult on your body and very costly, you are essentially guaranteeing more difficult outcomes for Black and Hispanic birthing people. The New England Journal of Medicine noted that the science behind it dates back to slavery and how Black bodies were viewed at the time. That is why the paid sick leave that Mothering Justice has fought so adamantly for is so important, because when dire outcomes occur after birth and you have to recover, you need more time and paid time to heal. The World Health Organization has recently declared that midwives are a key step to improving quality of care and reducing maternal and newborn mortality and morbidity. We need access to midwives more broadly, because without access, we can't have equity. Right now, midwives are not covered for community birth at all for reimbursement, and we are fighting to have all credentials of midwives covered so anybody can access midwives in any setting, home, hospital, or birth centers. And to that end, the State of Birth Justice Coalition, where I'm so honored to be a part of, has created a Michigan Omnibus bill package that will improve birthing outcomes by licensure of BIPOC-led birthing centers. And Birth Detroit, policy lead for the framework of the Omnibus, recently broke ground on the first Black birthing center in Michigan. Midwives need reimbursements through Medicaid, and Michigan is only one of 8 states that don't reimburse. We are grateful that Michigan requires licensed providers to receive implicit bias training and I was fortunate to be part of the Racial Disparities Task Force in the subcommittee led by Dr. Kennedy, who you saw, which you saw in the video. And that language that we collectively were able to craft helped inform the implicit bias training. We don't have data on the diversity of patient experiences during the prenatal stages. And so that's why we need a tool to measure when obstetric racism occurs so we can remove it from practice. And that's also included in the omnibus package. It is the examination of embedded practices through an anti-racist lens that caused the C-section calculator to be fixed. I have for each of you a copy of the legislative barrier document that explains why this omnibus package is a necessary step in birth equity and improving birthing outcomes for all people. If you support the most marginalized, we will all benefit. And also you want to just center joy in having the sacred practice of birth being honored in spaces that affirm you, in ways that you don't have to fear the outcomes for both you and your child. Thank you.
Thank you so much. In the interest of time, we do have one last set of bills to talk about. So I'm going to have everyone email us your questions, and we will get them answered by the people who testified. Thank you so much. Senate Bill 384 from Senator Hertel. I believe we have Kelly Steck from his staff joining us. If you would like to come up and give a quick, and then I'm probably going to bring all the other ones up together.
Wonderful. Good morning, Madam Chair, members of the committee. Thank you so much for your grace. My apologies for the delay. Not every day you get to live out the nightmare of watching your GPS's ETA tick from very early to very late as you're coming to testify on a bill. I'll be quite brief in this testimony. So very simply, Senate Bill 384 would prevent living donors of organs from being discriminated against in the issuance of life, long-term disability, or health insurance. So very simply, this bill would help ensure that for those who do choose to give the gift of life to somebody while they are alive, who are serving as living organ donors to people, that they do not face any ill events in the issuance of insurance following that. According to the American Kidney Fund, Michigan currently has the grade of an F. We have 0 of the 7 laws that they check for in place that sort of serve as protections for those who are donors. This bill would bring us to 1. We know that you all have been doing wonderful work with Rep. Brabeck and other members of the committee to increase our organ donation. I know every member of this committee understands the importance of giving the gift of life, of giving those organs, not only for those who are deceased, but for those who are able to give that gift while they are living. We have a set of constituents here with us today, David Galbensky and Mark Dybus, who are going to share their personal story of being a donor-recipient pair, as well as Dr. Doshi from Michigan Medicine to talk more broadly about the statistics. And Joseph Sullivan is here from the department if anyone has any more technical questions regarding the bill. Thank you again.
Thank you so much. And if all 4 of you would like to come up at once, that would be helpful. So Dr. Mona Doshi, Medical Director of the Living Kidney Program at Michigan Medicine. If you want to kick us off, that would be fantastic.
Perfect. And good morning to all of you and to Madam Chair and the members of the House Health Policy Committee. I am so thankful for giving me the opportunity to testify. This is my first time in support of the Bill 384 that prohibits life, disability, and long-term care insurance company from discriminating people just because they were former living donors. So the American Kidney Fund, the National Kidney Foundation of Michigan, Gift of Life Michigan, and all the transplant centers in the state are very supportive of the bill, and I have submitted their letters of support for review for the committee. So in the state of Michigan, currently there are 24,000 Michiganders fighting kidney failure. 16,000 of them are on dialysis. Patients on dialysis have a very poor outcome. They have a very high mortality rate, around 15 to 20% mortality rate. So if 10 Michiganders started dialysis today, then more than 5 would be dead by year 2028. Versus if they get a kidney transplant, then kidney transplants reduces their mortality by 60%. That means if 10 individuals got a kidney transplant, got off dialysis, then 8 would be alive at 2028, right? So kidney transplant saves lives. It also not only prolongs life, but improves quality of life. My patients who have received a kidney transplant can go back to work. Young females can have child. People can go back to school. They can live their life to the fullest. Dialysis is a very, very expensive treatment and does not give good outcomes, right? Dialysis costs around $60,000 per year versus kidney transplant. The upfront cost for the first year is $100,000, but thereafter, because of the surgery and the hospitalization and the medications, but thereafter, the cost of transplant is $10,000 a year, right? So after 3 years, transplant saves money. And guess whose money? The government's money, right? Because most of the patients who are on dialysis are paid for by Medicare. And if not Medicare, then Medicaid kicks in. So I believe kidney transplant is a win-win for all. It's a win for the patients, it's a win for the providers, it is a win for the government, right? And now, let's look at kidney transplants from a living donor is even better because you're getting a kidney from a healthy individual. That kidney is going to last way longer than kidney from a deceased donor. Kidneys from living donors last twice as long as kidneys from deceased donors, and you can time the surgery. A recipient who's anticipating getting started on dialysis can completely avoid dialysis, save all that $60,000 government money, and go start off with a living donor transplant. So what is then for the living donor, right? It is the personal satisfaction of seeing their loved one live longer and living life to the fullest, right? Living kidney donation is accepted on the premise that it carries very minimal risk to the donor, right? The studies have shown that the life expectancy of a living donor is equal to a non-donor. Their risk of getting kidney failure is no different than general population. Their perioperative complication is extremely low. The risk of death is similar to risk of you getting in a car accident while driving on a freeway. So the living donors do as well after donating their organ because they undergo extensive medical testing. They are seen by a group of providers, surgeons, nephrologists, the kidney doctors, social worker, nurses, dietitian, to make sure that the act of donation is not going to jeopardize their life, right? So here we, as medical professionals, are giving them clean bill of health, assuring that the act of donation is not going to jeopardize their life. And my social worker reassures them, and we reassure them that psychologically, mental health is not going to be affected. Unfortunately, we cannot say same for the financial risk that poses on living donors. Being discriminated against getting life insurance, disability insurance, long-term care insurance, we can't guarantee that. We cannot guarantee that they won't incur extra expenses. For example, travel
Dr.
to
Doshi, we have about 9 minutes left and we
Sure.
have 3
I'll
other
make
people,
it very short
so
now.
thank you.
Yes. Like, for example, travel to the transplant center for the surgery, for evaluation, all that is not covered, the lost wages and childcare. So these heroes, everyday heroes, do more than just saving a life despite getting into financial disadvantage. So I want to bring to this committee that as of last year, we had around 2,000 people in the state of Michigan waiting for a kidney transplant. Only 500, roughly 450, got a kidney transplant. So 1 in 4 Michiganders can get a kidney transplant and others are waiting. Live kidney donors can bridge that gap. And we need to make sure that we remove all disincentives in their way. And as pointed before, that Michigan has a grade F on the American Kidney Report Card. We are one of the 9 states in the country that has 0 Living Donor Protection Act. And passing this bill, supporting this bill, would be the first step in the right direction. Thank you.
Thank you so much. Eric
Thank you.
Ditchman with the National Kidney Foundation, if you would like to speak.
Sure. Good morning. Thank you, Madam Chair Rogers and Vice Chair Vanderwall, and members of the committee. I'm from East Lansing. My name is Eric Ditchman. I was fortunate to receive a kidney donation from my wife, Andrea Ditchman, in 2001. She wanted to be here today, but she's busy doing the people's work and enforcement at Lara, and since her regrets. I grew up in Port Huron, Michigan, and Andrea, grew up in Goodles. We met in high school. Soon after, I found out that I had kidney disease. My kidneys worked at 50%, which isn't bad, but they were both damaged at the time. What Dr. Doshi was talking about is when we donate one, we still have one very good, healthy kidney. I didn't have a diagnosis and was recommended to see a nephrologist yearly. At the time, I wasn't made aware of dialysis or the possible need for kidney transplant because the disease wasn't severe. If I was, as a teenager, I didn't sink in. I started to fall in love with Andrea, and pretty much there was no room for anything else in my head. 20 years later, Andrea and I are married. We have a 2-year-old son, Jacob, and we're living in East Lansing. Within 3 months, I suddenly lose the use of my kidneys. We call this end-stage kidney disease. In order to survive, I would need kidney renal replacement therapy, dialysis, or kidney transplant, as Dr. Doshi so eloquently described. Without either, I would die in a few weeks. I had an emergency start into dialysis. Within 3 months, I needed a kidney and wasn't really prepared for dialysis or a transplant. But Andrea immediately wanted to be tested to see if she would be a compatible match. Against the odds, she was. You know, it's been 21 years. I still get a little emotional about this, sorry. 4 months later after that, at U of M, she gave me one of her kidneys. The surgery went well for both of us. She was discharged in a few days and went home to be with Jake. She came back the next day to see me and then fell ill. They treated her down the hall at U of M for a reaction to pain medicine. Then she checked into the connecting hotel for the next couple of days to stay to make sure it all went well. I just want to briefly say that gift of life, as Dr. Doshi has mentioned, for us allowed me and my wife to adopt our daughter 2 years after that, and also allowed us to have a very good life together to this stage, along with home dialysis. It didn't last forever, but it was still an incredible gift and definitely helped while it was working. So in total, Andrea had 5 days off for the surgery complications and then another 3 weeks off for recovery. Fortunately for her, this living donation has not impacted her personal life insurance policy. Her work at the state came after a private employer at the time of the surgery. Thankfully, she has not had a need for her current disability, long-term care, or life insurance provided by the state. It is now 22 years past donation. This is a testament to the safety of living organ donation and the rigorous health screening that donors undergo. The Living Donor Protection Act will ensure that these policies will not be denied to her or if or when the need arises.
Thank you so much. I want to give some space for Mark and David, if you would like to share your story.
Madam Chair Rogers and members of the House Health Policy Committee, Mark and I are grateful for this opportunity to present testimony in support of Senate Bill 384 to create those protections for living organ donors against any increase in premiums or denial of coverage related to life insurance, disability insurance, and long-term care insurance. We have prepared written testimony for the committee that we've submitted to the clerk, Melissa Sweet, and we look forward to sharing briefly our personal experience with living liver transplant. So it was a beautiful fall September evening, about 4 years ago in 2019. When my wife, Lynn, and I arrived at my brother-in-law Mark's house. I was getting sicker and sicker as my rare autoimmune disease continued its attack on my liver. I was anxiously waiting on the transplant list for the availability of a liver from a deceased donor. Now, we entered that living room of Mark and Karen's house, and Mark had us both sit down, and after catching up a bit said, "Dave, I have some great news. I'm going to be your living donor. How does late November, early December look to get this done?" Now, you can only imagine the feeling of relief that overwhelmed me at that point. the tears of joy that streamed down my face, and the big bear hugs that were given. And of course, I let Mark know that those dates would kind of fit in my calendar okay. In late November at Henry Ford Health, Mark donated a portion of his liver to me and saved my life. He's my angel on earth, he's my hero, and he's really the only reason that I'm able to be here today to give this testimony. We've had the great pleasure of working with Senator Hertel and Kelly Steck to bring the bill through the Senate. And as has been talked about today, over 2,200 Michiganders are on the transplant list waiting for either a kidney or a liver that is resulting in an acute need to increase the number of organs available from deceased donors while furthering living organ donation. As Dr. Doshi has indicated, according to the American Kidney Fund, all 50 states are graded on 7 key criteria protecting living donors, and Michigan currently has 0 and has a grade of F. Now, protecting living donors from increased premiums or denial of coverage for life insurance, disability, and long-term care insurance is one of those 7 key factors. 31 states have already had legislation in place that provides this protections to their citizens. Now, by enacting Senate Bill 384 into law, Michigan will take that first step to improving its grade while eliminating an obstacle to those deciding to become a living organ donor. Mark, if you'd like to share.
All right. 2019, when I was going through the workup process to become a living donor to save Dave's life, I found myself in the little office of a social worker in Henry Ford, downtown Detroit. And we were discussing the ramifications of the decision to go forward. And as she described what those ramifications beyond the immediate
I'm so sorry,
concerns-
we have to adjourn in 30 seconds. Can you just give us the highlight?
Long and short is I went ahead with it, and I would appreciate you guys pass 384 in case something goes wrong in the future for a living donor. There's nothing to give them a safety net as it stands. Thank you for your time.
Thank you so much for your gift, and I apologize. We are at time. There being no further business before the committee, we will stand adjourned.